Hi everybody, welcome to Vent Rounds. Today we're going to talk about flow starvation, which also can be thought of as work shifting. In order to understand this problem, we need to review what it looks like when this problem is absent. We're going to be talking about the vent mode called volume control, which some of you may know as VC-AC, and in our taxonomy we call volume control dash continuous mandatory ventilation with set point targeting. That's what that little S stands for. The reason why this is the ideal mode to discuss flow starvation or work shifting is because there is a distinct relationship. As P musk increases, P vent decreases to the point where there is no support available from the ventilator. This is a sad situation. When we're thinking about volume control, remember that volume control is the same as flow control. If you're controlling one, you're controlling the other. First, let's quickly review what a normal flow waveform looks like in volume control ventilation with a decelerating ramp. So the baseline is here, beginning of inspiration is here, then deceleration throughout the rest of it, inspiration. Exhalation starts here, and then when exhalation is passive, it looks like this waveform here, so it exponentially returns to baseline. The pressure waveform looks like in a patient in volume control with a decelerating ramp when they're making no effort. The baseline now on this screen is down towards the bottom off the screen. So right here, this level of pressure is at the level of PEEP. As inspiration begins, we see the pressure start to rise here, and then because we're in a decelerating ramp, the pressure rises more slowly over this period of time until the inspiration ends and we turn to baseline again and we enter exhalation. Now, what does it look like when the patient starts to make effort? Remember, we're not controlling pressure here, so anytime you're in a volume control mode, you should look for what the patient's doing in the pressure waveform. A passive patient will look like this. A patient that's making effort will start to pull that waveform downward towards the baseline. So initially, it could be a small effort and look something like this. But as things progress and the effort gets higher and higher, this waveform can actually get deflected more and more. It can start to look like this, and at some point, if the flow demand by the patient is so high, this can actually get below the baseline. This is a pretty dangerous situation. The patient is now having to work against the ventilator to get a breath. In essence, this patient is working harder to breathe attached to the ventilator than they would be if you disconnected them and let them breathe through the endotracheal tube onto room air. Your ventilator will give you no alarms that this problem is happening, and this is why it requires a lot of vigilance to be able to understand when it's present. The next question you might be asking yourself is, what do we do in this situation? That answer is very context dependent. This depends if this patient is newly sick with ARDS, whether they're waking up and getting ready to wean from the ventilator, or they're in the in-between situation where they may be getting close to be able to wean, but they're not quite ready to come off. Here are some potential solutions. One thing you could do is increase the flow. On many ventilators, this means decreasing the inspiratory time so the patient receives the same tidal volume in a shorter period of time. Other patients may require a higher tidal volume. If the patient's very, very sick and you're worried about protecting their lungs from worsening lung injury on the ventilator, then you need to do more aggressive maneuvers, such as provide deep sedation and maybe even consider neuromuscular blockade or paralysis. So in summary, volume control is the same as flow control, and if I'm controlling the flow, that means the patient can't. Burn this relationship into your mind. In volume control ventilation or in PRVC ventilation, the higher the patient demand for breath is, the lower the amount of support they'll receive from the ventilator. In patients who are very sick with ARDS or metabolic acidosis, this is dangerous, and this needs to be amended somehow. And it's up to you as a treating clinician to decide how. Watch out for the next video and make sure to let me know what kind of content you'd like to see in the future.